just asked me to do a short talk about extended role of the epilepsy specialist nurse. As you already alluded to, I'm an epilepsy specialist midwife as well, and that's where my interest started 21 years ago. I was part of the Tropical Health and Education Trust doing training in Ethiopia, and it's been my intention ever since 2017 to get back there, but so far I haven't managed to get back, and COVID's made it even more difficult. But anyway, it's great to be part of this today. So I base my service and everything I do on the WHO ethos of promoting healthy living and healthy societies and preventing premature deaths, particularly sudden unexpected death and avoidable unnecessary disability, to try and make, despite having epilepsy, enabling people to have normal lives. Of course, I treat epilepsy, and I used to treat other chronic conditions as well, and use the latest available evidence, and I take part in research as well. And also offering care and support, not just to the person with the epilepsy, but also to their extended network, family, friends, work colleagues, etc. So my thing with epilepsy is it can be very difficult to navigate the journey alone. It's very hard to know what to do once you've been given a diagnosis. And it can leave you feeling absolutely lost. And even in the UK, when people get a diagnosis, they often crumble without the support network there immediately. And that's happened very recently. A patient who was referred to me this week, who was given the diagnosis last week and has cried ever since. No idea what to do with his life now. So I always say to patients that it isn't from just one person you will get support. It is multidisciplinary team support approach that you need. And of course, I'm just part of that, but there's also a neurologist in this country. They would have seen a neurophysiologist with EEGs and MRI brain scans. And then of course, there's a pharmacist who's going to issue the medicines and a GP who's going to be involved in it as well. But the most important thing is to have the patient at the centre of care. And that's what I think we do really well as epilepsy specialist nurses, is link people together. So you will see I've put some pictures of my colleagues here in Ethiopia, and this was some health extension workers I was teaching, but this was in, I think that one was in Jimma, and just some of our trainees, one of the times we attended there. 1 second. Right, okay, so what do I do? Well, first of all, I've already alluded to, I give diagnosis support. And then because I specialise in managing anti-epileptic drugs and have since 2006, I give medication management advice. So I titrate in medications, excuse me a minute, and withdraw medications as well. I have to be very mindful of other medications patients are taking. I order investigations, and I monitor and review what's actually happening with somebody's, not just their medicine, but also what's happening with their seizure control and whether they're having any adverse effects. I provide employment support in so much people can be treated very unfairly and unkindly by employers. Often people get put on extended gardening leave when somebody finds out they have epilepsy. But in the UK, epilepsy is covered under the Equalities Act. And if someone has a contract, we can make sure that the employer does reasonable adjustments within the workplace. It's one thing having epilepsy, but the people around you need to know what to do if you have a seizure. So it's very important for me to go through first aid advice with their loved ones and provide safety and risk assessment advice, and I usually do a SUDEP and safety checklist. I then provide education and information because I want my patients to become experts in their condition. I support other health professionals, doctors, consultants, health visitors, midwives, just about everybody, how to support patients with epilepsy, but also increase understanding. I also, a pivotal part of my role is providing preconception counselling and support during pregnancy. I also audit my service and do research, and I'm responsible for my own professional development. And I've become a national and international voice for people with epilepsy. And I've been doing other training in African states as well regarding epilepsy. So my expert prescribing support is make sure it's a suitable medicine for their seizure type, but provide information about that medicine in whatever format actually meets the needs of that person. We are influenced with choice through age and gender, and in this country, the prescribing has become much more narrow because we're not allowed to initiate sodium valproate, and that's what I'd really like Ethiopia to take on board. We need to be very careful of prescribing sodium valproate for women of childbearing potential because of the potential adverse effects on unborn babies. It's very important to think about contraception and pregnancy because many of the anti-epileptic or anti-seizure medicines reduce the efficacy of hormonal contraception. We also need to take into account people with learning disability. Are we looking at seizures or are we looking at behaviours that are causing the episodes? Ethnicity is very important because some people are particularly sensitive to our anti-epileptic drug, especially the Han Chinese. They're very intolerant, the majority of them, to carbamazepine and potentially lamotrigine. Also, we have to be very astutely aware that our anti-epileptic drugs can cause Stevens-Johnson syndrome. So you could potentially kill somebody just prescribing them our epilepsy medicines. We have to look at the other medicines they're being prescribed, and that's just not the medicines they're being prescribed by a doctor, but what they're buying over the counter or what herbal medicines are being prescribed that could potentially interact with our medicines or lower seizure threshold. We then need to look at their comorbidities, physical, mental and sexual health, because some of our medicines can definitely have a really profound impact on mental health. And if they've already got comorbid mental health diseases, which potentially up to 50% of people with epilepsy have, then we need to be astutely aware of that. We need to look at lifestyle because alcohol particularly lowers seizure threshold, but as do other substances. Smoking, for instance, can reduce lamotrigine levels. We need to look at things like shift work and sleepovers because of sleep deprivation leading to seizures, but also people remembering to take their medicines if they've gone to work or they're going to a friend's. We always talk about healthy sleeping because, of course, sudden unexpected death in epilepsy, we've become extremely concerned when people sleep alone because their risk of SUDEP is greater from sleep of a tonic-clonic seizure. We look at the safety elements, so that's where they store the medicines, their communication needs, the formulation that they're able to swallow or go through peg feeding, and where they store their medicines. But the most important thing, and certainly having worked out in Ethiopia, is continuity of supply. And, hello? Okay. We need to look at the leisure and sport that they do and what risk-taking they're doing and the psychosocial issues. In this country, we give free prescriptions for people with epilepsy, but definitely on the THET project, if you charged a small amount for a medicine, people were more likely to take it. And that was because of the fact that they felt it was of value then.
Sorry,
I think someone's got their mic on.
Yeah, Musimbi, can you please switch off your mic?
And we need to provide flexible individual monitoring and support and make sure we're monitoring adverse effects. So we promote and monitor adherence. We provide medication aids to help people remember to take their tablets and offer a shared care plan. So we actually form a partnership with patients, and we basically empower them to take control of their own condition, because one day, otherwise I end up with hundreds of thousands of patients. We need them to actually take over self-management. So I thought I'd incorporate some of the work I'd done in Ethiopia, because Zina asked me to do that. The main sites I've been to are Jimma and Gonda. Okay, and when I got there, honestly, I really felt, even though I travelled all around the world and worked in the outback with Indigenous people in Australia, I really felt out of my depth. And I think the first thing was to do a mapping exercise of what were we facing here. So many things in Ethiopia. I think failure to diagnose, inconsistency of care, failure of adherence to treatment, and then, of course, accessibility of the health facilities, and, you know, them having to walk miles, sometimes a couple of days, to come to the health facility. And their poor health in general and uncontrolled seizures, but also the attitude and knowledge of healthcare staff. And I literally saw staff I was teaching recoil when I actually touched the hand of somebody with epilepsy, thinking that I'd contracted it. Also inadequately treating it, so people carry on having seizures despite treatment, and lack of alternatives if there was treatment failure. And then you're also having to deal with false beliefs and stigma, and then the concealment of a member of the community who has epilepsy. And then we've got this kind of weighing up with the herbal medicine, with actually thinking that's more valuable, and that actually westernized medication isn't valuable. And then the family attitudes towards it. But then, of course, for myself and for people with epilepsy, fear of the harmful effects during pregnancy. And then you've got the problem with adverse effects and the cost of surveillance, and lack of availability of medicine, and then things like especially phenobarbital causing problems with memory and over-sedation. And then particularly with phenobarbital, because it's the most cheaply, widely available drug in Ethiopia, the problem, if you do stop adherence, then you can go into status epilepticus. And then interaction with other drugs, because it's an enzyme inducer. So the 3-year capacity building project I was involved with, the first and second year were mostly teaching and research in Gonda and Jimma, and then just visiting the rural clinics. But in year 3, boy, did we work. We conducted 3 rural clinics. I forgot how many hundreds of people we saw, but also we taught 127 health professionals at 9 rural health centres. I say we, it was me, covering hundreds of miles, and students, community health centre leads, managers, health officers, chronic disease nurses, community nurses, midwives, pharmacists, laboratory health professionals, and 1 environmental health officer. And then I did some additional training with health extension workers. So because they're manning the health posts, to make sure that they were well attuned as to what to do and how to manage epilepsy. So this was one of the teams that I work with, and I will remember them forever. They have a close place in my heart. Now, the obstacles for the patient was no demographic data for many of them, so no details of their birth or marriage or death or address. So trying to do follow-up can be difficult, and illiteracy and lack of understanding of the condition, and not taking their medicine, side effects, lack of supply, inconsistency of worth, and unable to afford the medicine, even though it was very cheap, and cultural beliefs. There's a strange noise going on again. I don't know what it is. Sounds like somebody's sweeping up, but anyway. Yeah. Difficult to access clinic, and and too poorly to manage the journey to get to the clinic in the first place. And many times we'd have a relative who would turn up rather than the person themselves, because the person was too unwell to come. And type of epilepsy was rarely diagnosed, and of course that can determine what treatment you prescribe. And the medications are phenobarbital, phenytoin, and rarely sodium valproate. But I'm very concerned that there will be an abundance of sodium valproate because it's not being prescribed so much in the Western world. And then, of course, the high injury and death rate. So the problems faced by the rural clinics, no doctors and lack of support, and desperately, desperately understaffed. Limited funds for medication and equipment, and poor consistency of supply of medicines. Extremely limited diagnostics. And of course, we don't diagnose epilepsy from MRIs or EEGs, but they do give us some further information about why somebody's got this in the first place. And poor infection control, in inverted commas, I'd say dreadful infection control, and remote and isolated with mostly ineffective communication systems. So that was one of our pharmacies, and it was really interesting for me to see that, because I could actually see how the patients were being given their medicines, and sometimes they were waiting all day for them to be issued. So just taking you on the journey, this is one patient, my daughter was actually doing she was doing photography, but that was one of her drawings from one of the people we saw. So that was with consent, and this were people just waiting for the clinic, but these were posters that were in the health centres about epilepsy, and this was kind of their health follow-up sheets. So very basic stuff, but it worked, and they could collate data from it, and you can see the abundant supply of phenobarbital here. And these were the little plastic sachets that the patients were issued their medicines in. And this was some more members of a team in one of the health centres that I met. So I cannot tell you how they impressed me, because they really helped mould, how I think about life, really. Superb history-taking skills, far surpassing many of our practitioners, many of our doctors in this country, because they've got to have good history-taking skills because of lack of equipment to do investigations. Expert knowledge and skills, and they were providing holistic care. And it's very supporting local and rural communities, and links with University Hospital for complicated cases, but that wasn't easy, because often one of us would pay for that, that person to go down, just because the person didn't have the funding to do it. But there was a good link there, and they could do that. Very positive attitudes despite limited resources, and autonomy, and I have to say a stoic attitude, completely. There we go. So thank you. That's my presentation and my experience, really, a little wink into my life, and a little bit of what I've done in Ethiopia as well. So thank you for asking me.
Thank you very much, Kim. As you said, you've done wonderful work there. And I just want to give the opportunity for the attendees, if you have any question for Kim, and you can put it on the chat, or you can actually, you can speak. And I want to start with a question. I living in England and knowing you and the work that you do, I've realized the importance, extremely the importance of having nurse practitioners who are experts in the management of epilepsy. And this is even more so in the African context, the same as in Ethiopia. What do you think, or how do you think we can develop the nursing service, or the nurse prescribing service education within the African context?
Well, certainly that's what VET were doing out there, and all the nurses who'd been trained through the capacity building project were prescribing phenobarbital mostly. And that was what the training was instilled at. So that's what we were doing, was providing training in order that nurses were trained, because there were no doctors in the areas that we were covering. So we weren't training the doctors, they'd been trained in Addis. We were training all the nurses. Saying that, many of the doctors joined in as well because of trying to develop their skills further. But for the majority of patients, as you know, in Ethiopia, they don't get access to a doctor. So joining a capacity building project would be the way to go. But it has already, obviously, Dr. Prevet and his team have done a lot of work out in Ethiopia doing that. So I think any nurse is capable of doing that, and certainly the health officers were equivalent of a specialist registrar in this country, and they were nurses, formerly nurses, not doctors, and their expertise in all chronic conditions and non-chronic conditions was excellent. So I think all nurses do have the capability of doing that. It just means they need to have the training. And certainly I can share the link where we've been doing some training in African countries, and there's been an expert panel. I have been included in that, which is a real compliment. And we've done the first lot of training, and we've also coming up to do a training for lay people now, but I'm sure there is something that we could link you up with.
Okay, thank you very much.
Any other questions?
Yes, I've got a question too on that subject. So looking at the role of the epilepsy specialist nurse, do you think it's something Africa needs to invest in, seeing that there's already a gap in terms of doctors? Do you think it could be the way to go for Africa, or are there other alternatives?
I absolutely think it's the way to go. Even in this country, the majority of our neurologists do not specialise in epilepsy. And they might specialise in stroke, or they might specialise in migraine, or they might specialise in Parkinsonism or multiple sclerosis. But there are a desperate shortage, even in this country, of neurologists who specialise in epilepsy. And I think when a neurologist has given the diagnosis of epilepsy, for the majority of healthcare services now that have an epilepsy specialist nurse, they're the ones that do all the work. So they're the ones who do all the prescribing, and there's no reason why they cannot diagnose as well. Certainly when you've been doing this job for a long time and you've built up more and more qualifications, there's no reason to think that a nurse is not capable of diagnosing, managing and treating epilepsy. And I actually think it's great because it does free up doctors. I do think it should be developed in Africa, because I think the prevalence of epilepsy is much greater in the African countries than it is in the developed world. So I think it's essential, really, and it is the way to go. Yeah, I think there should be a team of them. I mean, for us, for instance, I'm one person. I started this third service 4 years ago, and I started with no patients, and now I've got thousands, and it's still only me. I think if you do go about developing an epilepsy specialist nursing service, you absolutely need a contingency to not just be training one, but to get loads of people mentoring with that nurse to train other people up. It's essential. It's not, the NHS does it very badly. I think Africa could set an example with doing it well.
Thank you.
Any
Thank
other
you
questions? That's okay, yeah. No, is that it?
Okay. Okay, thank you very much, Kim. And I know you were in a hurry and you have to go. Thank you so much, and we look forward to seeing you another time. Thank you.
Okay, bye. Stay safe.
Bye, bye.
Bye.
All right.
Bye.
Thank you. Okay, thank you, everyone. And I just want to take this opportunity before I start.
Sorry, I think there's a question for Kim in the chat section.
Yes, okay.
Oh, okay. Sorry, I didn't see that.
Yes,
okay,
I
Kim.
haven't left. Yes. Okay.
Yeah.
Let me see if I can find it, because I was started logging in.
It says, how have you handled social, cultural experiences and beliefs interactions with modern medical treatment of epilepsy? What are the knowledge levels of facts on epilepsy in areas you have worked in?
So definitely when I was working in Ethiopia, and many people felt that someone having a seizure, this is what you're talking about, is it someone having a seizure was possessed by the devil, and or it was, especially if you got near their saliva, that this was the contagious part coming out of their mouth. Particularly if it had blood in it, and that if somebody was led on a fire, that you would leave them on the fire to rid them of the devil. And the way we tried to dispel these myths was by doing training for the health extension workers, and also doing training in schools to show what actually happens to the brain during a seizure, and why the seizures occur, and the fact they are symptoms of what's actually happening in the brain. I think I've come across most things. I've come across people with multiple bloodletting, and that was to release the blood to stop them having seizures. I've come across people who have been literally put in a straitjacket because they felt that that would refrain the movements and stop that. I've come across, very sadly, women who have been multiply abused because they have epilepsy. And that is because people feel their value in society is terrible, and that they're no better than an animal. I mean, what I've seen is tragic. I've seen multiple burns, and it's almost as if the burn, because people don't always think about the potential dangers regarding the fire, but when somebody is in a fire having a seizure, they're not even removed from it. That's the frightening thing. So how it's made me adapt my work in this country, we have so many people from different Black and mixed ethnic origin communities, and I've been able to adapt what I've learned in Africa, but certainly what I learned from the indigenous populations of Australia as well, when dealing with that, because many people won't even disclose they've got epilepsy because they're so ashamed. And they're worried about the stigma, especially when it comes to marrying. And many young women particularly are not even offered up for marriage because they have epilepsy. And there's always a great presumption that somebody with epilepsy has got learning disability. And even though learning disability population have a high instance of epilepsy, it doesn't mean that everybody with epilepsy has got intellectual disability.